Welcome to Health Choice Network and Alliance Chicago in Action COVID series, boosting efforts against COVID to mandate or not. Hopefully you are able to join our word cloud today and join us. Take out your cell phone and in the to line, put in 22333, and in the message line, put in COVID-19 heroes, and then let us know what you think. So welcome to our webinar today. It's very timely, and we have a great lineup of speakers today. So if advance the slide, we're going to go through our agenda first. We'll hear from both of our chief executive officers from both Health Choice Network and Alliance Chicago. Then we're going to hear from one of our colleagues at Alliance Chicago about some COVID-19 vaccine updates. Then we'll have a little national perspective and hearing from our colleagues at the National Association of Community Health Centers. And then we're going to hear from our own healthcare heroes. Two of our health centers we're going to highlight today, both Providence Community Health Centers and also Legacy Community Health. So we hope that you're going to be able to join us today. We have some interactive polls and a word cloud. So if we advance the slide, we'd like you to join in the word cloud today. So take out your cell phone and put in 22333, and in the message line, put in COVID-19 heroes. You'll get a reply back. And then we want to hear from you. And on the next slide, you'll see our question. What is one thing you appreciate about your coworkers, your healthcare heroes? And during the loop before we started the webinar, we got some responses. So I think on the next slide, we're going to see some of those responses. And there we go, a few of them. Dependable, dedication, family vibe, supportive, caring, heroes, vision, trustworthy, love, support, empathy, commitment, resilience, flexible, community-minded. That defines our healthcare heroes from our community health centers within Alliance Chicago and Health Choice Network. So first, we're going to hear from both Health Choice Network and Alliance Chicago's CEOs. And first up, we'd like to hear from our colleague, Dr. Fred Rockman, the CEO of Alliance Chicago. Fred, how are you?
Hi, Tim. How are you? Can you hear me?
Perfectly.
Right. So, you all, it is really with some mixed emotions that I welcome you all today, because on the one hand, it is always to me personally inspirational and enlightening to spend time with you at these webinars. But on the other hand, I'm sad that we still have the need to do them. And we just realized the grim statistic in that 1 in 500 Americans has now died of COVID. So could you advance the slides for me, please? So, the initial optimism that many of us felt during the summer, we had an initial beginning to return to some normalcy, and we're seeing the encouraging trends of the decline of COVID cases has given way, of course, now to the surge that we're experiencing, both in cases and hospitalizations and sadly deaths. And next slide, please. And even more so, it becomes sobering when you think that that initial optimism was wrapped in the rapid uptake initially of immunization and the promise that that held, and then a rapid decline in those immunizations, that in many ways, the combination of that failure to immunize more of our population, along with, maybe that relaxation of feeling that things were on the decline, led in many ways to the surge that we're experiencing now. Next slide, please. So sadly, I know we always have a health equity lens and disparity lens at health centers. And so we see, even in the average aggregate national statistics, still the suggestion of disparities along racial and ethnic lines. And next slide. And also between geography settings. I think we missed one. There was an urban-rural one as well. Those statistics become even more sobering when we drill down a little bit more into it. For example, if we look at younger age groups, working age groups, African Americans and Latino Americans are 3 times more likely to die and Native Americans 9 times more likely to have died from COVID. And the geography lens is similarly concerning. So although there's that overall statistic that's bad enough 1 in 500, if you look in geographies like Alabama or New York and New Jersey, it's 1 in 300. And that's even worse because in New York and New Jersey, those statistics were from early in the epidemic, before we had a sense of what to do to prevent it. Whereas in Alabama, these are late deaths, where hopefully we would have had the opportunity to impact that curve. This image, I hope, begins to define for all of us the role and the work that we have at health centers. It looks at the percentage of the population that is vaccinated by social vulnerability index. And sadly, you see this tremendous disparity from communities where we really have done a good job of erasing that kind of disparity in vaccination to ones where we are really at the other end. And the challenge I think we all face at health centers is to move everyone into that upper blue, where although we're dealing with populations and communities that face high social vulnerability, we're still able to protect them through vaccination. Next slide, please. You can see these kinds of disparities that prevail. This is the challenge that we have, that there are sadly some trends amongst what willingness is to vaccinate. It's led to some of these thoughts about mandates and things like that. So these are going to be some of the challenges that we're going to be digesting today. Next slide, please. Although we're focusing on immunization and we're going to focus on a little bit on surveillance and other kinds of responsibilities that we have to direct impact of COVID, I want to remind us that the pandemic has some significant secondary impacts, including increase in stress-related disorders, impact of delayed and disruptive preventative primary care, workforce challenges and stress in our own workforce, and finally, social determinants-related stressors. Next slide, please. I hope that in your mind, you have some kind of version of this graphic. We know that the major impact on health in general, even prior to COVID, came from all of these social determinants. I think it's one of the major contributions that health centers have is being at that intersection. And certainly you could take that outline, whatever outline you have for social determinants, and see how COVID-19 has actually exacerbated in all of those areas. And it's something I hope we're all keeping in mind. Next slide, please. So as we think through, beyond today's discussion, what are broadly mandates for health centers? Certainly promoting vaccination and providing direct care and contributing to surveillance and testing activities are key in COVID, but also hope we're also working on these secondary needs, attending to general health needs, including mental health and impact of stress, identifying and attending to these social determinant impacts, continuing to advocate around health equity, and attending to internal stress, amongst our staff. And the last slide, please. I hope we could take also an optimistic turn, looking at how we could turn some of the insights and some of the push that we've had through the pandemic to begin to realize some of the opportunities for transforming healthcare by having an innovative lens to what we're doing going forward. I know this is beyond what we're doing today, but I hope many of you will be joining us for our virtual conference next month, where we'll have a chance to explore some of these broader issues. And so with that, let me turn it over to my colleague and brother in this work, Alex, who's going to give some reflections on digesting for us some of President Biden's mandate. Alex?
Thank you, Dr. Rockman. You'll be proud, as the non-clinician on the panel, I actually have a lot of the health determinants and social indexes on my talk. So good afternoon, everyone, and welcome on behalf of HCN and our amazing board of directors and associates. We want to once again thank our healthcare heroes. You continue carrying out the mission with both courage and empathy. We recognize you, We see you, and we're continuing to humbled by your outstanding efforts. I'm looking forward today to the webinar today. We have two very distinctive and contrasting opinions related to mandating vaccinations. Now, with the administration rolling out their six-step approach, we have varying thoughts. Here in Florida, we have two schools of thoughts, and they're using social media and general news outlets to continue to confuse our consumers, our communities. We're proud here at HCN of our associates. We now have achieved over 94% vaccination compliance without mandating it, using Dr. Long and Dr. Esmond and all the education and constant emphasis on how we can best support you, our health centers, and making sure that we're ready to not only come on site and provide the assistance that you have always depended on us for, but also making sure that as more organizations mandate those vaccines, the travel restrictions, the trainings, that we can still bring to you that educational information and have no disruption in the access to best practices and the latest in clinical value-based services and type of advice. As Dr. Rockman mentioned, I didn't know what he was going to say before this. I'm going to reemphasize. I now serve on 3 different health disparities and health equity index task forces here in Florida. And it's amazing to see what COVID has done as far as worsening, but highlighting across our communities those disparities. Just recently, I was able to examine some of the pre-COVID social vulnerability indexes, some of the county health rankings, and even the HRSA publishing in 2019, 2020 on health equity. And it's very clear that we're going to see those concerns across access and how those mandating vaccines may influence or further divide our communities. I strongly believe that us working together like we're doing right now, sharing best practices and those lessons learned, sometimes the hard way, we can turn all the negativity into a positive. I know our communities require and rely on us for that. With that said, we do have some promising bright areas in the community. 2 cities and municipalities, one in Texas and one here in Tampa, have been recognized for not only developing a health equity guide for community preparedness, but how COVID has either hurt or helped those processes. The Robert Wood Johnson Foundation just published those in late August. So we want to continue this approach of today's having the discussion of what are our challenges ahead as some of these mandating principles go into effect, how the states are reacting. So you can imagine the state's approach, both from a governmental perspective here in Florida and Texas, seems not to deter 2 counties, Harris County in Texas and Tampa, Florida here, from continuing their push to make sure their community is prepared and can respond to some of these divides that this pandemic has created across health equity. So despite that, I think we have a great line of speakers today. I was able to see some of the presentations earlier on, and I think you'll stay entertained with some of our amazing speakers. I want to thank you for your service, your time, and your incredible commitment to mission. And I also want to highlight our annual conference once again, due to COVID and our safety concerns for both you, our members, our customers, our community health centers at large. We've gone again to a virtual environment. So we're very proud to partner once again with the Alliance Chicago, our sister network, and our family to provide you an amazing group of speakers, both nationally and recognized across the pond as well. We're bringing international speakers to hear some of the best practices we've heard as the entire globe struggles with this pandemic. So with that, Dr. Long, I'm going to hand it right back to you. And thank you again.
Great. Thank you, Alex. And thank you to your leadership at Health Choice Network on this. And also thank Dr. Rockman for his clinical leadership and leadership at Alliance Chicago. And together, both networks are moving the needle on COVID-19. So thank you. So our first speaker is going to be one of our colleagues at Alliance Chicago, and you may have seen her before, Shelley Sital, who's going to talk with us about some vaccine updates. So Shelley.
Thank you, Dr. Long. Good afternoon, everyone. Go ahead and go to the next slide, please. I just want to take this opportunity over the next couple of slides to just kind of set the stage for the speakers that we're going to hear from later, and kind of give you a sense of where we are now. So this first here, I just want to highlight to you that we are doing really good in terms of seeing an uptake of vaccines. I want to make sure we see things in a positive light. I know it's easy to get a little bit beaten down by some of the negatives that we see in the press, but I just want to highlight specifically that we have over over 92.8% of folks over the age of 65 who've at least received one dose at this stage. So it's very promising to see that we are getting closer and closer to a nice solid number for herd immunity. Next slide, please. So the other thing I wanted to mention is just to highlight to you all that we do see the highest uptake of vaccines is in fact the Pfizer-BioNTech or Comirnaty vaccine, and that's kind of the focus of the vaccine mandates and things that are being discussed right now at the FDA and the CDC. But let's not forget the J&J vaccine is still out there and that it is still available to give your patients, and it is a quick way to get at least one dose out to folks who may be hesitant to get the mRNA vaccines. Next slide, please. The other thing, just building on from what Dr. Rockman said earlier, we do see that the race ethnicity of the fully vaccinated population tends to be on the white non-Hispanic side with the highest uptake, followed by Hispanic Latino and then Black non-Hispanic. So there are definitely some areas that we could be focusing more and more on getting people in the door to get vaccinated. And just to note too that this data here, this visual comes from the CDC, and that it is only reflecting 63.6% of those who've been vaccinated. So also just noting for those of you that are documenting and reporting to try to capture the demographics of individuals that you're vaccinating. Next slide, please. So Dr. Brockman shared this slide earlier, and I just want to take an opportunity to kind of hone in a little bit further. So 14.2% of the people that were surveyed for this particular survey that was collected from August 29th through September 4th, so very recently by the CDC, did still indicate that they are pretty hesitant to get vaccinated, are not planning on getting vaccinated. And the sample size that they used was about 19,000 individuals, so a relatively significant number. And most importantly, I want to just identify too that the highest area of people saying that they did not think they would get vaccinated were in the age category of 18 to 29, and additionally those who are in rural communities. Just a thought to think about as you're targeting individuals and thinking about who's coming into your health centers and finding ways in which to create some messaging that goes specifically towards those categories of people who are really demonstrating that they still do not want to get vaccinated. Next slide, please. So again, same thing here. I just want to highlight where we are. So you see in the three highlighted circles, that the lowest age groups are the ones that are still getting COVID at a higher rate and are demonstrating a nice steady uptake of vaccination. But as you have people coming in who are perhaps going off to college, who are perhaps starting high school and needing to get vaccinated, please do think about trying to co-administer the COVID-19 vaccine, as those are really the age groups that we find are continuing to have some hesitancy in getting vaccinated. Next slide, please. So again, I just want to also create some positive momentum here. We are seeing an uptake, obviously, as Dr. Rockman mentioned earlier, there was a really nice significant increase in vaccinations with a bit of a dip, excuse me, in the summertime, followed by a nice steady increase over the last few months since we've seen an increase in cases. Next slide, please. Excuse me. I also want to take a quick moment to just clarify some confusion that continues to happen around the language between third doses and boosters. The third dose specifically refers to getting an additional dose of vaccine after a primary series is completed. So in this case, specifically for Pfizer and Moderna, after the 2 doses are completed, that there may not be an immune response that's as sufficient as we initially may have considered there to be. So for both Moderna and Pfizer, we know that the immune response was projected to be over 90%, but now data has demonstrated that for people that are immunosuppressed in one way or another, and I'll go into details as to who may be qualified under that category, they may not have had that 90% immune response. Boosters, on the other hand, really refer to those individuals who got an initial sufficient response to the primary series and then have had it wane over time in terms of effectiveness. That's similar to what we see for vaccines such as tetanus, Tdap, in those series that you know of that people have to get booster shots 10 years or so later. So just keeping that in mind as people may come to you and there's some confusion around the language around what a third dose is versus what a booster dose is. Next slide, please. So what do we know now about third doses? So as I mentioned, CDC is recommending that moderately to severely immunocompromised individuals should receive an additional dose. And this really includes people who have been receiving cancer treatment, may have had an organ transplant or a stem cell transplant, and then also people that are on high-dose corticosteroids or other drugs that might be immunosuppressants. And generally, there is a list available now. So if you haven't looked at it, there is a list on the CDC website of exact ICD-10 and CPT codes that correlate to the people who kind of qualify under this third dose recommendation that they have released. Next slide, please. So what do we know about boosters? The Advisory Committee on Immunization Practices met on 8/30, so very recently, and they at that time did not make a recommendation for booster doses. And I'll go into some information that they shared at their meeting just in a moment here. But they are going to convene at the end of this month on 9/29 to review additional data and really consider the booster recommendation that's come forth from the Biden administration. The FDA is also conducting an independent evaluation, and they're going to be working on determining the effectiveness and safety of a booster dose. And essentially, they're going to be the ones that really create the regulatory allowance to allow for booster doses to be provided. So at this time, again, the recommendation is to stick with providing third doses just to individuals who are immunocompromised, not booster doses to those who may just need a boost in their immunity. Next slide, please. So some of the information we received at the ACIP meeting that occurred on 8/30 is really demonstrative of where we are in terms of the effectiveness of these vaccines. So the visual here that you see was a combination of 4 different studies that looked at where we are in terms of vaccine effectiveness against hospitalization. So as you can see here, there's still about a 70% or above vaccine effectiveness against hospitalization. And on the next slide, you'll see that there is unfortunately a decline in effectiveness against infection. We do know, and I'm sure you've heard this across many platforms, that there are less and less individuals, or more and more individuals, apologies, who are getting infected, who may be asymptomatic or fairly mildly symptomatic. However, this still is demonstrating to us that the vaccines are working, and even though effectiveness against the infection has been reduced, people are still not getting hospitalized. Next slide, please. So I want to just leave us on some thoughts here. COVID-19 vaccine notables that I just want us to take in mind as you're kind of thinking about what's next for you and your health center is the mRNA vaccine products that you may have had at the beginning. So let's say you had Pfizer and now you have only Moderna. It's okay. It's not recommended, but it is okay if you must give individuals coming in for their third doses a different mRNA product, just making sure that you're noting that appropriately. The other things I want to make sure we are aware of, J&J is not being discussed. I know people are asking about it. The FDA and the CDC does plan to review data as to whether or not individuals who receive the J&J vaccine early on should need either a booster dose or an additional dose for those that are immunocompromised. So that information is still pending. At this time, if someone were to come to you and ask for J&J booster dose or a third dose, please just remember that that isn't currently a part of the recommendations from either CDC or FDA, so those are not authorized at this time. Additionally, just to note as well, some clinical trial participants who have received the active, not the placebo vaccine, of other non-authorized or not approved vaccines such as Novavax could potentially be considered fully vaccinated. So that is an additional consideration when you have patients coming in who say they may have participated in the trial. Currently, that Novavax vaccine is the only one that is approved, or not approved, rather allowed for in terms of being considered fully vaccinated. And then last but not least, please remember, as I mentioned earlier, Full administration is permissible and really encouraged for those individuals over the age of 12 as they come in for their school vaccinations, as they come in for work mandating vaccines, as you'll hear about in a few moments. Make sure you do encourage them to also get the flu vaccine, to also get other vaccines at the same time as their COVID vaccine. And if they're not there for their COVID vaccine, really encourage them to consider getting that, and that you are able to provide it to them at the same time, at the same day. The recommendation from CDC is really that you make sure you try to administer it either on an opposite arm or in a different location on the arm in which you're administering other vaccines. I believe those are my slides, so thank you. Back to you, Dr. Long.
So Shelley, once again, fantastic information. Thank you for sharing all that with us. I also want to let people know, and we'll put it in the chat, that about 48 hours after today's webinar, you'll get a copy of the recording and also Shelley's slides and everybody else's slides. So again, Shelley, thank you. So next, we're going to do a little interaction and make sure everyone is awake. So we are doing a little poll, and we would love everyone's responses here. And I think you can only vote once. Some of us might be from Chicago and try to vote twice, but we're going to have you just vote once. So here is the #1 poll question. Is your health center mandating vaccination for employment? So it's either A is yes, B is no, C is unsure. I believe on the next slide, we will be able to vote right here on the quick poll screen. And I will be tabulating all of these results right now while they are coming in. I see a number of them coming in, so we're going to give it a few more seconds. Please vote for the poll. Is your health center mandating vaccination for employment? Yes, no, or unsure? And I am going to put down my calculator now and let us close the poll and see what we have. Okay, mixed bag. 55% say yes, 30% say no, and 14% are unsure. All right, thank you very much. It's good to know where everyone is at on that #1 poll question. So next, we're going to hear from our national partners, and Brandon from the National Association of Community Health Centers is going to talk to us about that specific question, mandating COVID-19 vaccines. So Brandon, welcome.
Thank you, Dr. Long. I appreciate that. I did want to take a moment and thank ACN and Alliance Chicago for just being so timely with this webinar, and certainly your invitation to speak on today's presentation. Next slide, please. All right, I won't read through this statement, but our mission statement, hopefully everyone's aware of our next mission statement. So we'll go to our next slide, please. Thank you. All right, so thinking about the fact that I've been at NAC now a little over a year now, start last July, I wanted to make sure you all were aware of who I was. Probably sure you've seen my name in several publications and probably in some trainings you may have participated with me, but I want to make sure you all are aware of my background, where I came from, and what my role is here at NAC. So as a director for health center operations and HR training, I'm actually going to start at the bottom of my bullets and work my way on up. I'm a former hospice CEO here in Southern Maryland, but more importantly, I have a lot of health center background. So I'm a former health center COO for my home state of South Carolina, spent some time in New York State as well as Pennsylvania prior to coming to the DC area. Also, I'm also a current board chair for Health Center FQHC here in Maryland. So I want to make sure you all are aware of my health center background. So within my NAC portfolio, ops portfolio, I'm responsible for the regional operations training. So I'm sure you all, some of you may participate in those, hopefully, and the practical arts of health center ops, cultivating health center ops and elevating health center ops, PACO, CHICO, and ECHO, as well as I serve as the lead at NAC for emergency preparedness, recovery, and response activities. We held, if you participated in this past spring, we held an emergency management and response learning collaborative partnering with the National Nurse-Led Care Consortium, and we're going to continue that with another learning collaborative this year. As well as I serve as the lead for rural access to care learning collaborative activities. Again, we did one in this past spring, and we'll continue again as we head into year 2 training season. Perfect. Okay, next slide, please. All right, so I'm going to take a few moments of your time today and just share some updates relative to hopefully you've seen this, our NAC and Felsman-Tucker vaccine mandate FAQ that we created collectively. It's a comprehensive document, so I'll talk a little more about that. I'll go over, just reiterate NAC's statement position from recently on 9/10 from our president and CEO, Tom Van Coverden. I'll take a moment to reiterate some of OSHA's recommendations. Particularly, I'll pull some pieces from NAC's hosted webinar that we held on August 5th. I'll take some highlights from that session and reiterate during today's presentation. And lastly, I'll flag just some federal and state policy implications or considerations for you, certainly as your organizations proceed to next steps in compliance and implementation of these vaccination requirements. Next slide, please. Okay, so as I mentioned, so the NAC Felsman-Tucker vaccine mandate FAQ, we pushed it out, we rushed it and pushed it out. A lot of work on the back end for myself and certainly our team members at Felsman-Tucker. But it's a pretty comprehensive 9-question FAQ, and it consists of 9 questions, particularly those hot topic questions. Certainly at the time, the health centers had around vaccine mandates, and obviously given President Biden's recent announcement regarding Medicare and Medicaid certified facilities, I still feel like many of these questions still have some significant relevance to health centers. So I'll take a moment and read through just a couple of them. You see 2 there in particular. I'll skip over number 1 because I think as I get into the interim rule, that may be voided or nulled. But for example, question 2, can a health center require employees to provide proof that they've received the COVID vaccination? So you see there, yes, given except in jurisdictions where it's prohibited. Certainly EOC has determined that inquiring an employee's vaccination status is not a disability-related inquiry, but that information is still confidential. Another question I want to highlight too was question number 4, whenever you get a chance to take a look at this document. Are patients entitled to know the health center staff members are vaccinated? So short answer is they can know in aggregate. So we can say 80% of our health centers have been health center staff have been vaccinated, just cannot share individual information, keeping in mind that that's confidential. Another question, can employees be exempt from a health center requirement to be vaccinated? Short answer is yes. I'm sure we all are very aware of this. There are some exemptions specifically for religious exemptions as well as medical exemptions. So just keep in mind, again, certainly with President Biden's recent announcement, I know there's been an increase in religious exemptions. So just make sure health centers ensure that you all have appropriate processes in place to handle these exemption requests. And one last question is just, can pregnant employees be exempt from vaccination? Again, short answer is yes. Pregnant employees have protections under ADA and Title VII of the Civil Rights Act. So although pregnancy itself is not an ADA-covered disability, conditions or medical conditions that develop during pregnancy are ADA-covered disabilities. So that's just a few I want to highlight for you. So secondly on there, we have the interim rule. So that's what we're waiting for. Chatting with our panelists before we started, we're in a wait and see. NAC is in a wait and see position right now. CMS is developing an interim final rule with a comment period expected sometime in October. We'll all see that when it comes out. But until then, CMS does expect all of our certified Medicare and Medicaid certified facilities do comply and act in the best interest of your patients and staff and comply with the vaccination requirements that were just announced. Facilities are urged to use all available resources to ensure that employees are educated, are vaccinated, and certainly have the support to get the vaccinations done as quickly as possible. Next slide, please. Again, just highlighting NAC's statement. I won't read through the entire statement here. This is a quote from President Tom Van Coverden, our president here at NAC. But just want to point out so he did state in here, throughout the throughout this battle, the Biden administration has been very supportive of health centers in every step with resource and support. We are grateful for today's announcement of there's 25 million rapid tests are going to be going out to over 1,400 of our health centers and certainly food banks across the country. So again, making that point, in addition, there are some additional comments later on where it states that, since the direct allocation of vaccines to health centers, since that began in late December, health centers' ground strategy has really been to build confidence around the COVID-19 vaccine, and you all have really been doing that, certainly from the numbers that we just saw previously. So overall, we just strongly urge health centers and their staff to comply and get vaccinated in the best interest of public health. Next slide, please. All right, so in addition to CMS's regulation, obviously OSHA does play a huge part in the staffing portion of this. So as a reminder, I did want to take a moment and remind you all of a few of these OSHA recommendations. So as a reminder, OSHA's ETS, or Emergency Temporary Standard, went into effect back in July. And its purpose was really to require employers to protect workers from exposure to COVID in all the settings, with some exceptions where employees provide some health care and health support services. The acting director, I know this was a question probably a month or so ago, was do health centers, does this apply to health centers? And the answer to that is yes. And the compliance deadline for provisions related to physical barriers and facility ventilation, that was back in July. Just putting those dates out there to keep in mind. OSHA is following a discretionary enforcement approach to avoid citing employers who miss compliance deadlines, but they're trying to make a good faith effort to comply with this ETS requirement. Relative to COVID-19 hazards in the workplace, additional information just to be reminded of as it relates to OSHA is under the ETS, employers must conduct a workplace specific hazard assessment. So make sure you all are doing that to identify potential workforce hazards or workplace hazards. The COVID-19 plan must address the hazards identified by that hazard assessment and include policies and procedures. That's going to be critical to minimize the risk of transmission of COVID for each of your employees. Employers must designate one or more workplace safety coordinators, we'll talk about that in a second, to implement and monitor that plan and ensure the compliance with all aspects of the COVID-19 plan. So as I mentioned, so the COVID-19 plan safety coordinators have a couple of responsibilities. One, they are required to, implement that plan. They're required to monitor the effectiveness of the COVID plan. They need to be knowledgeable of infection control principles and practices, and also, and more importantly, ensure compliance with all aspects of the COVID-19 plan. So OSHA also has recommendations around employee training. Employers should conduct trainings for employees on policies and procedures, what you have in place, what needs to change, and what the work that you're doing to make those changes, implementation of your written COVID-19 plan. Employees need to be aware of that and knowledgeable of that. How your health centers assess workplace hazards, and certainly and also consider if your health center has a mini, or think about having a mini respiratory protection program. So those are just some recommendations around the employee training aspect of the OSHA ETS. Looking at enforcement, again, I mentioned OSHA will follow a discretionary enforcement approach, but keep in mind they will be trying to comply with the ETS guidelines. And I want to make note here, as of August 1st of this year, OSHA and its state plan partners have received more than over 68,000 COVID-related complaints. So they will be working on addressing these complaints as they come in. And as of January, initial COVID, OSHA penalties for COVID-related citations were more than $4 million. So that's just some numbers for you to think about as we enact these procedures. Lastly, with the additional resources, I did have, and I'll get to that in a second, but lastly, I want to encourage you all just to review NACHC August 5th. I mentioned the August 5th OSHA ETS webinar. It's pretty informational, certainly provide a lot of guidance. Again, this has been over a month ago now, but still very relevant. You can take a look at that. You can search that through NACHC's online library. You should be able to find that recording there as a video recording. Now, I know one question over the last few weeks has come up, certainly is around PTO. So I know there's been some questions that I've gotten relative to whether health centers need to pay, allow PTO for employers, if they need to go out for a COVID, if they have a COVID illness. So just questions around getting clarity around that. So just for your own iteration, under OSHA, a health center must allow an employee to use their PTO for COVID-19 vaccination or vaccine appointments and related symptoms. And additionally, if the employer is required to allow staff to use PTO if they have COVID. So you're required to allow staff to use PTO if they have COVID. That was a question that came up to several of us. So again, health centers are not obligated to provide additional PTO. Just remember that. But I have made note that if an employee has a position that is able to be remote, you can allow them to be remote and just pay them normally. So just keep that in mind. That's just some areas where you can consider when you are trying to address, or if you have questions around the PTO concerns. Okay, next slide, please. All right, I want to take a moment and highlight some points to consider from the federal and state level. Keep it in mind that we, NACC, we don't have specifics. We're again in a wait and see position on when this final rule comes out, which will provide certainly further clarity, and we can again provide some guidance to you all as appropriate. So again, the OSHA regulation, understanding it will impact health centers with 100+ employees. We know that, but I put this here because I want to make sure we, reiterated that when that CMS interim rule comes out with a little more clarity, it more than likely would be a stricter regulation. And again, that will be the regulation that we will have to comply with. So just keep that in mind, certainly as we wait and see for this interim rule. And that CMS interim does come out, it will take precedent. I put in here flags to consider the testing exemptions that are in place now. When that final rule does come out, if they remove those exemptions, then just know that that will be voided. So that will not be an exemption that you can utilize for employees. So again, once we see this final rule, we'll be able to provide more clarity and guidance around that. Additionally, understanding that there is and there will be some staff turnover, which we don't want, but knowing that will happen around this regulation. As you identify staffing concerns around this matter, just please feel free to send me those concerns, and I'll share at the tail end of my presentation our regulatory affairs email, so you can share that with them as well. And our reg affairs division will be able to kind of elevate this to our legislative leadership as appropriate. So just keep that in mind. NACC is again continuing to work for you all and make sure that you're getting the resources you need. So again, we're committed to providing additional support once that final rule is announced. So we'll be prepared to provide a webinar with some additional TA and support to assist all health centers in implementation and compliance. But again, until then, we don't have any recommendations just yet until this final rule comes out. Okay. Next slide, please. Oh, one thing, you can stay on this slide. One thing I forgot to mention is, remember, when that interim rule is announced, the date of that announcement is when that rule is in effect. Even if it says you have certain areas where they want you to, comply with regarding that rule, just know that the date of that announcement will be the date that the interim rule goes into effect. Okay. I always like to take a moment and plug in any of the upcoming events that NACC is hosting. I am part of a couple director team. We're driving this our Farm IT conference that we hold every year, every fall, upcoming on October 19th and the 20th in Vegas at the Caesars Palace. So if you've not registered, please jump on there and register. Early bird ends on the 21st of September. I will be leading a few sessions with some amazing speakers, as well as my colleagues. So we're looking forward to having you all there. It will be a hybrid conference, very similar to the recent CHI conference. So just keep that in mind, and we'll look forward to seeing you all there if you're able to come. Next slide, please. The next slide, I'm just adding just my contact information. So feel free to shoot me an email if you have questions. More importantly, if you have questions around the regulatory matters here, certainly with OSHA and the CMS, copy me as well as the regulatory affairs email. And that regulatory affairs email is run or controlled by our director of regulatory affairs, Vacheria Tetson. So she and I kind of tag team leadership with these matters at NACHC. So feel free, if you have any questions or concerns, shoot those to myself and this regulatory affairs at NACHC.org email. Next slide, please. I think this is my last slide. Yeah, so again, last plug, shameless plug from NACHC. I always like to make sure health centers are aware and are utilizing the health center clearinghouse. There's a lot of great resources there. Whenever we host our trainings, I know I host our pharmacy office operations and certainly some other office hours that we do. Those are all recorded and loaded into this clearinghouse, as well as publications that we push out as well. So be sure to check that out. And again, if you have any additional questions, you have my email, you have the regulatory affairs email, and we'll look for those to assist you in any way possible. Thank you.
Thank you, Brandon. We really appreciate all those words of advice and waiting on that rule to come out, because I know it's going to affect all of our health centers. So we want to appreciate your time. Thank your colleagues at NACHC for joining us today.
Thank you, Doc.
Right, well, as we move on, we are going to do another poll. So this is our poll question number 2. So you don't have to take out your phone. You can get ready right here on this platform. So poll question number 2 is your state mandating that healthcare workers get vaccinated? So the question is your state mandating that healthcare workers get vaccinated? So A is yes, and then if you could just type in your state into the chat, and we'll be taking a look at that. B is no, or C is unsure. So here we go, right? The poll is now open. So why don't you go ahead and let us know what your answer is to this quick poll. Is your state mandating that healthcare workers get vaccinated? It's either yes, no, or unsure. And we'll give it a minute. While we tabulate these results, I will get out my abacus and see if that will help us get to the answer here on the poll, the quick poll. So is your state mandating that healthcare workers get vaccinated? And if it's a yes, try to put your state in the chat for us. We'll be looking at those states in the chat. So why don't we go ahead and close that poll and we will see the results. So it looks like no, states are not mandating healthcare workers get vaccinated. At least the majority of people on today's quick poll, 55%, said no, state is not mandating healthcare workers get vaccinated. Followed up by 27% are saying yes, and 18% are saying unsure, don't know. Thank you for that quick poll. And as we move on, we are now going to hear from our health center heroes. We hear from 2 doctors up in Rhode Island. So Dr. Saul and Dr. Gates, welcome. And we're looking forward to hearing you talk. Take it away.
Thanks, Dr. Long. Hello. We could, we'll take our next slide, please. So I'm Dr. Gates. The other gentleman up here is Dr. Saul, my boss. We'll be talking about mandating vaccinations today.
I feel like kind of Teller. I'm going to be Teller.
Oh, wonderful. Well, we'll switch roles a little later. That'll work well. The joys of being a physician behind an employee health program. Next slide, please. So my role here, what I would like it to be, is just to point out that vaccination has been mandated for a long time for kids. And I'm not sure about adults. In healthcare, we've been treated differently many times. But if we look at public health mandates, they generally have occurred at the state level if they're going to. We just got through that poll. But I'll call out this 1905 judgment. That's you can look it up as Jacobson versus Massachusetts. And that's when the Supreme Court upheld the mandated smallpox vaccination, which started in 1809. And I'm told George Washington actually mandated that his troops get vaccinated as well. By 1922, the Supreme Court had upheld a school vaccination mandate. By 1963, 20 states had mandatory school vaccination. 1977, all 50 had some. And those are some of the vaccines that we're all familiar with. Those are some of the terrifying disease that science helped us get rid of, or at least mitigate mostly. But the right of a state to mandate something for public health has been upheld several times by the US Supreme Court. Next slide, please. Now, why would we do this? What's different about kids, and what's different about adults, and what's different about these vaccines? Well, if we look at what was happening during the 20th century, smallpox was killing like 48,000 people a year, measles 500,000 people a year. My goodness, I didn't know that about measles until I looked at this thing. And as we got into the year 2000, that MMR vaccine looks like it was saving roughly 600,000, 650,000, almost 700,000 people a year because of these vaccinations. So as we start to see this value, not only are the lovely little children being protected, those kids that were unvaccinated could literally have been causing the death of other little kids that weren't vaccinated. So we had to do something to intervene, mostly because kids don't wash their hands very well. Some of us healthcare workers don't either. Social distancing can't be practiced very well by kids. They're not good at it. Staying home couldn't be done very well because we all have to go to work, or at least we used to before COVID. And then proper masking is tough for them too. That being said, nationwide, if you look at it, less than 1% of the kids enrolling in school use the medical, religious, philosophical exemptions, mandatory vaccinations. So that means 99% of the kids going to school are getting vaccinated. Next slide, please. Now, I wondered whether the COVID vaccine would measure up to this. So this is data from the CDC. And as we heard earlier in the talks, we look at the 2020 year, 643,858 people died of COVID. That's 11.7% of all Americans who died in 2020 died of COVID-19. If we look at breaking that out by those who were not fully vaccinated versus those who were vaccinated, you can see that it is about 90% effective at preventing death. So it's not quite as good as some of those other vaccines we had, but clearly it is 90% effective at preventing death. Next slide, please. It looks like it measures up. So, although you have the right to make bad decisions that impact your personal health, you can smoke, you can drink, you can not wear a seatbelt. Those bad decisions, when they start to impact the health of other people, active tuberculosis, no good, no good. Click one more time for me. Your personal liberties end when they encroach on the personal liberties of somebody else. And that is, generally speaking, the logic behind mandating a vaccine. And with that, I will transition over to, was it Penn? I'll become, no.
I'll be teller. I'll just sit here. And,
okay, excellent.
Yeah. Anyhow, thank you all, and watching the clock. These slides will be available. I'm going to go fast, but all these ideas are yours to share. So earlier we hinted at most public health laws originate at the state level. That's because of the 10th Amendment to the Constitution. All rights not reserved by the federal government go back to the states. However, at certain times, the federal government can and will impose things on the states, such as seatbelt laws. If you want federal tax dollars to build a highway, your state must have seatbelt laws. They love to do this. Can you click the slide again? So can they do it? You better believe they can, and they will do it. If you're a federal grantee, if you read the bottom of your 330 grant, there's all sorts of things about equal opportunity employment. That's how the government issues policy. That's how they lead. And if you really have fun with it, you know you can't buy your steel in Canada to build your next clinic, and you're not allowed to open a clinic in Havana, even though I've tried. Next slide. The other way you'll see the feds doing this is read your next FTCA deeming letter. Read it closely. And if you pay very close attention to the bottom, what they're saying is, hello, hospital. If you don't want to let these FQHC doctors have admitting privileges, you can say a lot of things, but you can't blame the FTCA. If you say this is not good enough malpractice, the federal government will cut off all funding payments to your hospital until you agree with us. Have a nice day. We suspect this is probably one of the main mechanisms for the upcoming federal mandate. It's going to be tied to receiving Medicare and Medicaid dollars. So suddenly you're talking about 95% of the hospitals and all of the FQHCs. And that is a very blunt tool, but it would supersede a lot of states' things. And that's how we got a lot of civil rights and voting rights through back in 1968 and 69, was that same mechanism. Next slide. And of course, when we started this, we thought the initial thing was, oh, my health center wants to improve vaccination rates. What do I need to know? Click the button once, please, Alexandra. And then we realized that this really is that email you're going to get, or that discussion like, oh, crap, what do I got to do now? What do I need to know? Next slide. And of course, I wanted to point out that Dante, one of the most famous poets in Western history, said that there's a special place in hell for people who put their personal welfare ahead of others. But if you don't want to read Dante, Buddy the Elf said it best. Ronnie DeSantis is indeed a cotton-headed ninny-muggin. And for the record, I'd like to say that neither the comments of me or Jay Gates represent the opinions of the Providence Community Health Center, HCN, Chicago Alliance, or anybody with good taste or class. Next slide. So here's what we started doing initially. And for us, hey, guess what? Rhode Island is one of those states that now mandates that all healthcare workers must be vaccinated. And we're doing pretty well, but it didn't come about overnight. So these are some of the best practices that we've been pushing all along to get everyone ready and to get there. And you'll notice, like many of the other people around HCN and all the other health centers, we've been talking about that constant messaging and going after myth busting, just getting out there ahead of it, clear and concise triage protocols, testing, all these things. We gave call-in radio shows for the staff to vent their worries. And realistically, the whole beginning of this is, as a health center, our first duty is to provide a safe environment for every patient and every staff member. And that's where OSHA comes in. Because do you think you'd be allowed to have somebody with active TB walking around your clinic? No, OSHA says you need to have TB screening protocols of some sort. And of course, when you do this, you have to address rumors, even those that are unspoken. So hooray, you have a show and no one asks questions. Remember, one of the great big things driving people nuts is these ongoing stories about infertility and radio locator chips and on and on and on. And I always like to point out to people, you're worried about the vaccine having a tracking chip? Have you seen what your cell phone can do? Next slide. And doing this, there we go. That longitudinal messaging, we've been on this. We started this even before the vaccines were available. Click the button once, please, Alexandra. Thank you. So we had everybody on hands for doing these call-in shows with everybody, particularly during the lunch hours. Click a few more times the slide. There we go. And notice that what we were saying from the start was we will continue doing X, Y, and Z to stay safe until the vaccines are ready. So we're really pushing these ahead to break the cycle. And also some of the constant messaging is we were going after that myth that, well, it's just like flu. I'm like, no, it's not. This is exponentially more contagious, exponentially more deadly. And masks are good, they're not perfect. And so that messaging has been there all along. And just like you heard earlier when you looked at the Supreme Court ruling, your personal liberties end when you're infecting other people. Next slide. So these were, of course, the strategies. I think we covered some of these at some of the other Alliance Chicago and HCN things, but these were strategies we were using all along, and hopefully you were too. And yeah, there's actually social science behind this. Next slide. There we go. So stage one, remember when everybody was all demand and no supply? Hey, great. Those first adopters, and notice the very interesting graphic. Thank you, Dr. Gates, for doing all the graphics on this. There is your rabid Apple fan. And if you see how those people get new devices and how they spread the culture, that's amazing. And we, of course, went out of our way to look at this saying, who's going to be first in line? And we deliberately chose people of color and people from those high-risk groups that we knew were going to have vaccine hesitancy. We wanted them first, and of course, it was way more than a photo op. Okay, they were in line in front of the CEO and the physicians. This wasn't about photo ops. This was about reducing healthcare disparities. They were the highest risk. And what we found, of course, is those people later became ambassadors to drive the change in the culture. We had proactive support from senior leadership and HR. And yeah, we did actually say, we're going to pony up an extra day of PTO if you have side effects. Only 3 people took it, but that extra safety net got a few more people vaccinated. And of course, we were making it as easy as possible to get vaccinated. We had the employee health team going out to the site saying, let's go today. Next slide. Stage 2, when you move beyond early adopters, is let's turn it into a game. Of course, we used game theory. We began reporting vaccine rates by site. We threw in pizza parties, we threw in prizes, and sure enough, we got a lot more people vaccinated. Next slide. And then we hit phase 3. And this study, and a lot of this comes from Omar Galarraga at the Brown School of Public Health, coincidentally the home of Dr. Ashish Jha, who is now our new local dean. He is amazing. But we are looking at incentivizing, and there are some relative values there about what it takes somebody to do something. But there's a tipping point. And if you are going to do pro-immunization or if you want to incentivize something, at best you're going to get about 10%. So it's important to do, but don't think it's perfect. And if you notice there, we went from 65% to 75%, and then it hit that ceiling again, and that was kind of our operational threshold of everyone else is now hesitant. The numbers you're about to see are everybody. You tried to play the exemption or not. The numbers you're about to see, we don't have religious exemptions in Rhode Island. So hooray, University of Rhode Island said everyone must be vaccinated. Oh, but here's a very easy way to do religious exemptions. And then they shouted, success, 98% of our people are vaccinated, or declared an exemption. No, the data you're about to see is the Providence Community Health Center really, really pushing employee health and not having a religious exemption. Next slide. And so, of course, this is where the strategy really kicked into play. We've got many, many physicians of color. We had a very, very active outreach team talking about how to immunize high-risk populations and addressing everything from Tuskegee and all the social racism that goes into it. And one of their first meetings, they said, you do know we hire people from the community, right? Maybe these same strategies for the community should be deployed in employee health. And so we did. And so we actually began to identify who had not been vaccinated, and we were reaching out one at a time. And the real discussion is not punitive, it's tell me your worries, tell me what's going on, help me understand. And of course, many of us even said, if you're worried about, going anaphylaxis, I will go with you to the vaccine site. And click once more, Alexandra. And what we found is that 12 more people were so blown away that leadership would approach them and say, I will go with you. They promptly said, oh, this is really important. Let me go get vaccinated. And so we got up to right around 80%, and then we hit the ceiling. Next slide. So this is, of course, where we got stuck. And we began the discussions at senior leadership saying, we're going to plateau at 80 unless we mandate. And these were the hard discussions, and these are the topics. And you as physicians and leaders of your clinic, you need to be at the table, and you need to remind people there is a lot more than politics in the world, because masks aren't going to do it alone, because unvaccinated staff can infect and kill our patients. Ooh, liability. Because unvaccinated staff can infect our other staff. Ooh, OSHA. And one more click. And more importantly, your unvaccinated staff can drive up your health insurance rates. Now that's really ugly in public. So if you get to this point, okay, and you're about to say, oh my God, we have to tell the world we are going to mandate vaccines, I need you to please put on your public health hat and avoid copping out. Please, under no circumstances, play this card. All right? If you say, because the feds told us so, I'm looking at you. Basically, don't be a public health wimp. Do your job and teach your senior leadership and teach your staff. That's what's really going on here. So don't cop out and say, because they told us. I'm like, You might hide behind that a little bit, but you still need to educate. Next slide. And of course, let's say your state decides to mandate, or let's say your health center under federal rules as a federally funded agency now needs to mandate. Here's probably what you need to do in terms of planning and coordination. Next slide. Kudos to Dr. Gates for that lovely meme. This is a photo of me at my last job hiding under the desk. This is what medical directors look like in the wild. So the discussions right now is you can't wait and see. You need to sit down with your senior leadership and say, let's do contingency planning now. What would a mandate look like here? And if you click one more time, these are almost inevitably the topics you need to raise, and you need to raise them now. It begins and ends with communication. But notice, how am I tracking vaccine status? How do people request exemptions? How do you verify that that exemption is legit? What kind of exemptions do you take? What kind of deadlines? What are the consequences if you do not comply? How much staff can you lose if you dig in your heels? And we'll come back to that in a minute. And are you prepared for unions, grievances, and people threatening lawsuits? We have had those talks, and you should too. Next slide. So here is the big thing right now. You need to have this talk with everybody. If you look at the feds and what they're going to say is, oh, you need a religious exemption, maybe, but you're not obligated to it. Remember, the feds defined the floor, and if you have a religious exemption, it's really vague. And so we have had that discussion, and actually the Rhode Island Department of Health gave us the cover we wanted. The Rhode Island Department of Health in their mandate said there are 5 valid exemptions, and they did not give people the option to click a box and say philosophical exemption. And I'm going to show you that slide next. They also very clearly defined what is a medical exemption. And if you've been on the vaccine teams, you know what the contraindications are. And basically, we're going to give you the vaccine unless you had a damn near allergic reaction, almost died with the first one. And of course, you need to have a process to look at that exemption and evaluate its validity. Next slide, or next clip, there we go. Don't think you can just say, we'll evaluate exemptions on a case-by-case basis. You will get so far behind in a hole. You can't do that. So I strongly recommend having a standard exemption form that your health center, your state, somebody defines. We gave you a copy of Rhode Island's. It's in the chat bar on the side. You can download it and take a look at this. They do say it must be signed by a physician, nurse practitioner, or PA. And the way it's set up, you're basically picking from exactly 4 conditions, 1, 2, 3, or 4, or there's a 5th deferral you can play. But what they're really saying is, okay, physician who is about to sign this, does your patient really have any of these 4 conditions, yes or no? Now, I've gotten several letters from physicians who were reluctant to sign that, but they went ahead and wrote, they don't have any of these, but. And then we were able to evaluate that. And it turns out having palpitations before you receive the vaccine is a normal reaction. And no, we're not going to exempt you from dose 2 because you felt your heart, go fast because you were getting a vaccine. So next slide. So here, of course, is the key shot of that Rhode Island thing. And notice there are the 4 big things at the top. There's 2 for myocarditis, and there's 2 that basically say you damn near died during dose 1. And they're talking anaphylaxis. They're not talking, I got the sore red arm with the beef. They're not talking, I had fevers for a day. They are very clearly in the small print on this form defining anaphylaxis, like something you would remember needing an EpiPen or going to the ER for. The next one is very key. It's immediate allergic reaction to a previous vaccine component. And a lot of the docs in town who may or may not, they kind of say, oh, I had a sore arm. I'm like, that doesn't comply. And if you follow the asterisk, what they're really talking about is PEG and polysorbate. And polyethylene glycol is really, really interesting to be an allergy because if somebody's actually had Go Lightly, they're consuming PEG. We do happen to have an allergist on staff, and no one's played this card yet, but if someone were, our response probably would be, show me the medical records, and let's have that free allergist talk to you. Is that really an allergy to one of these? Because I really want you to get vaccinated. Next slide. And that consistent messaging as we began pushing this out a couple weeks ago, the why, and these are the myths, and you can click through these. Notice what's written in red. These are actually talking points that a lot of our clinical leadership have been using. I had COVID, therefore I'm immune. Well, cold viruses are coronaviruses. You're not immune to the cold, are you? That whataboutism is a nice common phrase. Well, I heard that somebody who with a vaccine got the infection. True. But the messaging we found that works well is the vaccine gives you 99% protection, but the unvaccinated are 100% vulnerable. And you can go into the data and show them, but man, I'd rather be vaccinated because you're more likely to live. And of course, don't let anybody compare this to flu. That is just a false comparison. And the punchline that one of our docs tried out on a couple different people and said it worked was this: comparing COVID to flu is like comparing the Los Angeles Lakers to your 6th grade basketball team. So it's a little bit of humor, but it's wrapped up in that whole idea of trying to get ahead of a false narrative or a false comparison, and minimization is what psychologists call that. One more, and of course the question of the religious mandate comes up. Please talk about this with your senior leadership. I bet people on this call are going to be all over this. I am a practicing person of faith. There is no religious exemption where I trained from. So you'll want to be proactively find statements from major world religions and proactively communicate them, because somebody will download a 14-page thing they found on the internet and write their name on the top and sign it. And it'll be full of all sorts of religious verses from the major world religions. What is your team going to do to respond to that? And in Rhode Island, luckily, we had the cover of the state health department. There is no religious exemption for a healthcare worker to not get this COVID vaccine, if I said that correctly, you know what I mean. Next slide, or I'm sorry, next click. And this is a true joke. So a Greek Orthodox priest, a rabbi, and an imam walk into one of our break rooms to have lunch. Because, next slide, it turns out that these people, these are their day jobs, are as physicians here. So we are blessed to be large enough that we actually have most of the major world religions represented with theologians who happen to be medical leaders. And so from the beginning, they were instrumental in helping us to shape our response to the employees and get ahead of this consistent messaging. And of course, the ultimate Catholic card, do not play this nuclear weapon. The joke, of course, is the last time I checked, the Bishop of Providence reports to the Bishop of Rome, and Francis likes this. So there's your Catholic du jour, a moment of the day. Next slide. And of course, now the vaccine's here. What do we do? Well, from the start, the messaging was concise. It was clear from the CEO on down and all the senior leaders. This phrase shows up over and over and over. Our first duty is a safe workplace for you, the employee, and a safe workplace for everyone who comes here. And it's constantly messaging the why behind this. Next slide. And of course, it comes down to communicate, communicate, communicate. And you can click through a few of these, Alexander. I'll follow you. Notice here that we didn't say you're fired, okay? What the mandate says is you are unable to enter our facilities. Your job description says your job is requiring you to be inside the facility. Look, you're not able to do your job. We're not firing you, but we'll accept your letter of resignation. If you don't give us the letter, we'll assume you have resigned. And so non-compliance for us equals auto resignation. HR people love that. Not only can the person, they won't have a mark on their medical record, were you ever fired? Hooray, the doc's happy, they can go find a new job. What it also means is you can't get unemployment if you resign from your job. That's unhappy, that's HR law. We also went through this with ongoing communications with the outliers. We started with 100. We had 600 people. We knew 100 weren't vaccinated. We began reaching out to them. Then it was 50. Then it was 40. And we're constantly talking to those outliers in person now. We do a lot of emails. By the way, make them blind carbon copy. Otherwise, everybody else will know who's not vaccinated and they'll form their own union. But basically, we're doing confirmation receipt on all these communications. And then the supervisors went out and in a very respectful, very careful, cautious discussion, we're asking, can you explain why? Okay, we don't want this to be punitive, thou shalt. It really is, help me understand. Tell me what worries you. And that includes now the medical leadership has been approaching individuals one at a time. Next clip. Now, of course, employee health went out. We're like, we're here with the vaccine. Tell us when you want to be here. We will bring it to you. Trying to tear down those barriers. Next click. And of course, continually monitor. So our database was set up so we were always monitoring. And as of this morning, I'm watching the numbers go down. And of the outliers, there's a comment saying, did they tell us why? And if you notice the line on the bottom, This is very strategic. We are on a countdown now for an October 1 deadline. You must have 2 vaccine doses in your arm if it's Moderna or Pfizer, or at least 1 J&J. And of those remaining people, we have gone to them saying, please tell me your intentions. Behind the scenes, I'm getting ready to post jobs. We can't wait. But more importantly, we're asking them, would you like to discuss your worries with one of the physicians? Next slide. So does it work? And I think the reason y'all asked me here, not only did we get to be first in line to try this, workforce is really, really hard. Recruitment and retention, you can't get enough of these people. There's a shortage and you've got to do this wisely. And so I just want to give you kind of a rule of thumb. If you shoot from the hip and go after your employees in a punitive fashion, say you must comply or I will fire you, it may not go well. So here in Rhode Island, Community Health Center A has 375 employees. They've already lost 33. Next click. Health Center B, oh my goodness, they did some things they wish they could do over now, but they're in the process of losing almost 10%, a lot of support staff. And then of course, next click, a little tiny one went first, and they, because they were the first in, of course, they got the punishment because a lot of people defected up the street to another place where they didn't have to be vaccinated. And of course, there's us. If you click once and pause there. So what we're talking about here with these numbers, remember, we don't have a religious exemption. We had a very, very clear way for people to request an exemption. We were very proactive in our communication. We were very, very on the ground. Tell me what your fears are, doing everything that we're doing in the community with a vaccine hesitant population. How are we doing? Well, 610 people when you start counting subcontractors. And if you click the slide, I'm happy to report with about 2 weeks to go, and click again and click twice actually. There we go. Without any religious exemptions, we're coming in at 97%. So we're down to about 11 people who have not declared. Now already you can see I've got one person playing the myocarditis card. The exemption letter, I've sent it back to the physician saying, did you get an ultrasound? Are you willing to say on paper they definitely had this? We have one deferral because they just got monoclonal antibodies on the 91st day. The person's ready to get vaccinated. We've got a few people who are going out on FMLA. They're aware they need to be fully vaccinated when they come back. And of course, somebody who was planning to retire in August moved it up by 2 weeks. So I bring this to you to say that if you do this well and you focus on communication and you actually work with your vaccine hesitant population, your patients, help me understand. You can actually preserve your workforce. And if we do our cards right, okay, we'll lose 10, at most 20, but we're talking about 2 to 3% of our workforce instead of 10%. And to me, that's a victory. It's not pretty, but it's a victory and a step in the right direction for public health. So last slide. So I want to thank everyone for the opportunity to speak today, and I'll turn it back to you. Take it away.
So I want to thank you guys mostly for the content, but probably the delivery is the best. And so many of us think that, you know, a show, you know, between two ferns might be a great option for you guys. And we're going to be your agents in the future and promote you guys. So thank you once again. Again, Dr. Gates, Dr. Saul, phenomenal content, phenomenal statistics, and great job there. Thank you.
Thank you.
So as we move from the Northeast in Providence, we're going to go down to Texas, and Dr. Nguyen is with us. She was seeing patients earlier, and now she's joined us to talk about what is going on in Texas. Welcome, and we're so happy to have you back. We so appreciate it. Oh, we cannot hear you yet. I think it might be, yeah, because on the, you're unmuted. There we go, I think.
Is that better?
Perfect, just talk loud. Yes, perfect, thank you.
No, I just wanted to echo that presentation was super helpful. So thank you, Dr. Saul and Dr. Gates. Sort of wished I got that presentation maybe last month, because we're in the middle of our process for the mandate. And so I just wanted to share pretty briefly, because I know we're running low on time, how we move through our process and where we're at. Our deadline was October 8th. And so we are just in the, actually, we just started the accommodation review process this week on Monday. And so our committee that is meeting is due for, you know, releasing whether things are being accommodated or not by the end of this week already. But I love just the examples that were given in the last presentation regarding, you know, different tactics that were being used to really reach the staff who needed, who could have benefited from more focused attention and education. So I thought that was great. I didn't have time to prepare slides, but I did send over to Stephanie just the email that went out, and thought I could just highlight some of the pieces there and really just open up for questions. I think that would probably be helpful for the group. So Stephanie, I don't know if you have the email available to show, but basically I can kind of talk through some of it while she pulls it up. But it was about a month ago that we met actually with Methodist. And as you all know, Methodist was sort of in the front lines of pushing the mandate way before anyone was really talking about it, and really withstood a lot of the social media feedback and lawsuits, and really came out of it with very impressive numbers. And so we do have a partnership with Methodist through a fellows program, and so we did meet with them to ask for advice, and so a lot of the process and policy we put forth was very much a mirror of what they did. Of course, by the time we pushed it out, there was much more acceptance, and very quickly there were a lot of different healthcare agencies pushing for a mandate, and actually, for that matter, non-healthcare agencies like airlines were already pushing, and so that was helpful. We had a very short timeline because we wanted our drop dead, deadline to be before, as much as we could before the fall, and so October 8th was the soonest that we could make it. And then we just backtracked from there to create different milestones of deadlines. Because of Moderna and Pfizer, we knew we wanted to make sure that there was enough time for the second dose. So our mandate is that the second dose is in by October 8th. So just like in the last presentation, it's very important to focus on why we're doing it. And similarly to other agencies, it's really our best way that we believe can help protect not just our staff, but our families and patients that come into our clinic. And so we really focused on that piece. We created videos, as you see here, for the announcement of the mandate. And if you scroll down, Stephanie, we basically made sure we had all of our dates in one place for everyone to see. Because really not everyone, I don't know, maybe 50, 60% of people actually read emails that we send out, but we wanted at least an email that had everything so that they could refer to it. So even if they ended up deleting the email thinking it wasn't important after the fact, if they realized that that was an important email, they could go back to it. In our state, we did allow for religious and medical accommodation, and so we had to make sure we created those forms and had that process in place. For us, we had to scramble a little bit to make sure the tech platform we were using was user-friendly, and we also created some additional videos that showed staff exactly how to upload their vaccine card, what to do if they misplaced it, how to access the accommodation forms, and so we just worked hard to try to get as many potential questions as possible. And then the last piece that we organized quickly was essentially like a live town hall, but we called it a COVID-19 conversation. And we had that last Wednesday. And we purposely timed that COVID conversation about a week after we sent out the email. just because, of course, as you can imagine, right when we sent the email, the next day there was a lot of discussion and rumbling about staff being upset and wanting to organize protests, which they never did. But there was just heightened emotion there. And so we wanted to make sure there was enough time that had passed before we held a live town hall. And so we took answers that were submitted previously, and we had the opportunity to organize it. We had, I was present to represent the providers, but we also had our infectious disease specialists to speak to any questions that were very specific to COVID. And then we had our chief legal officer to discuss just the compliance and legal matters around the mandate. And so overall, I think the conversation went well. We did open up for additional questions. And in the chat, we got 80 plus questions. Of course, we didn't get to all of them. And so all of those have been now transferred over to an FAQ sheet. But very similar to what Dr. Saul said is many of the questions were, why are you making us get the vaccine? And why are you making us put something in our body that we don't want to? And we just kept very consistent that we aren't making our staff get the vaccine. However, they have a choice. And so if they still want to remain employed, then this is what we're requiring of them. And so it was just a matter of managing and articulating that message. And so right now, I think our FQHC is about 1,300 staff members, and we have about 30 or 40 accommodation requests to move through and make a decision on by the end of the week. Prior to our mandate, our numbers were about 82% of our staff was vaccinated. So we knew we still had a push of a little bit more to get to full vaccination. I think, Dr. Long, if there are questions for anyone on the panel, maybe that's a good time to do that.
That is great. Thank you so much. And if you don't mind, we put this in the chat, and we're also going to send this out.
Yeah, it's okay.
Great. Thank you so much. And thank you, Dr. Nguyen. Thank you, Legacy. You guys are leading there in Texas. We really are appreciating it. We'll be taking all of the questions that are in the chat and put them together and then send them out later. So I want to thank you for your time.
No, thank you so much.
Great. So as we close today's webinar, we want to highlight a couple of things coming up. Again, Alliance Chicago and Health Choice Network really appreciate your time on these COVID webinars. But more importantly, we'd like you to join our annual virtual conference. It's free. Sign up. You can take your phone out and scan to register here. These are it's a 4-day conference. There's 1 day of pre-conference and then 3 days of full programming, as you can see. And on the next slide, you'll see each day at a glance, I believe. We move to the next slide there. Again, you can pull out your phone and scan the QR code here to register for our conference, which is on October 12th, 13, 14, and 15. It's all virtual and all free to members of Health Choice Network and Alliance Chicago. So I want to thank everybody for coming to today's COVID-19 webinar to vaccinate or not to vaccinate. So again, from our sponsors, HRSA, who has been able to allow us to put this together. We thank HRSA, our funder, and we thank you, Healthcare Heroes, for joining us today. And I hope everybody stays healthy, and we're gonna make it. We're gonna make it through. Have a great day, everybody.